my CP PACES examiner since 2016. Arabic and Iraq board supervisors and examiner since 2000. Published more than 40 papers in peer-reviewed international journals of medicine. So, welcome to Dr. Abbas Al-Sharifi.
Assalamu alaikum. Chairman, dear colleague, friends, it's my pleasure to be here to give this lecture. And actually I would like time to Dr. Rafit and Dr. Muhammad for inviting me to give this lecture. Actually, they gave me the schedule initially 30 minutes, and I arranged my lecture for 30 minutes, but now he told me just to make it 20 minutes just for the sake of the lunch. Anyhow, maybe I am going to skip some of my slides. This is Baghdad. يعني اليوم يمكن يسعدنا أحد الأخوة الزملاء القصيدة بغداد حبيبتي. This is Baghdad, our capital. It was and it will stay city of history and culture. It will stay beautiful in spite of all challenges and obstacles that we are facing on a daily basis. Usually, sometimes I start my lecture by some photo from Iraq. This is okay, and as you know, that ischemic heart disease is number one of causes of death all over the world. And this study difference between 1990 and 2020, it remains ischemic heart disease as number one cause of ischemic heart disease. And usually patients with ischemic heart disease are presented with chest pain. And chest pain now does not mean by these two words, chest pain. This is according to the guideline, just a few months released from the American College of Cardiology and American Heart Association. They put this schedule evaluation and diagnose chest pain. Each letter of this chest pain, it means something. I choose this lecture because acute coronary syndrome, I am sure that here different specialties. I am not talking just a physician or a cardiologist. We are talking for surgeon, for gynecologist. So I am sure everybody is interested to hear about coronary artery disease. So chest pain, see meaning chest pain. Add, for example, high sensitive troponin, which now this is very important in the guideline, and rule on diagnosis or exclusion of a chest pain. And every letter, it has some meaning. I will not go in detail about it. And this is the typical, this is the chest pain of a patient coming to us with acute myocardial infarction. Usually, put his hands like this. If a patient coming, and this is what we face in our daily practice, if a patient puts his hand like this, 90% this is due to the acute coronary syndrome. While if he's just pointing like this, 90% this is not acute coronary syndrome. It may be other causes of chest pain. You know that chest pain could be cardiac or non-cardiac. And also there are some symptoms. There is some difference between the presentation of acute coronary syndrome between men and women. Usually both of them coming with a chest pain. But sometimes, usually the ladies, they are coming with symptoms other than the chest pain, like shortness of breath. So if we face a patient, lady with a shortness of breath, we have to keep in our mind also could be this due to acute coronary syndrome. And now, usually we teach our student, the patient coming to the emergency department, he put his hand like this is typical chest pain. If put it like this is atypical. Now this word become discouraged. American cardiologists say this is cardiac or not cardiac. That the picture that I showed, the patient put his hand like this is cardiac. If put like this is not cardiac. So this is one of also of the changes which happen in the guideline. We have the acute coronary syndrome in 3 categories. either patient with ST elevation and high STEMI, or a patient with non-STEMI or unstable angina. Just to show you that the atherosclerosis process starts in young age, in early age, and there will be advance or progression according to the comorbidities. For example, hypertensive, diabetic, smoking, make it is rapid than in the patient who don't have such symptoms. And this, that means this lead to accumulation of lipid, foam cell, macrophage, platelet, okay, and so many things, and then it will lead to the formation of plaque. And this plaque usually is stable, but for reason or another, if a patient getting good injury of this plaque, and this is what lead to dislodgement of the plaque, and this will be rupture. A rupture of the plaque. What happens if they get rupture of the plaque, and this will lead either to the occlusion, complete occlusion of coronary artery disease. If the patient gets complete occlusion of coronary artery disease like this, okay, then the patient will be presented with STEMI MI. If there is partial occlusion, then the patient will be presented with non-STEMI MI or unstable angina. And this is the typical ECG changes that you see it in a patient with STEMI MI. There is hyperacute ST elevation and all over the bleed. For example, this patient, you see that this is extensive, and this is the ECG of a patient with left main coronary artery disease. And that while the patient comes with non-STEMI, usually don't get ST elevation, but sometimes may get ST elevation transient, then it's followed by diffuse T-wave inversion, and the treatment is different and between STEMI and non-STEMI. Patient coming to the emergency department, okay, this is how they have said team at the entrance of the hospital, take him to the chest pain unit, and this is quick history, physical exam have to be done, ECG show the ECG changes that I mentioned, and here we have to focus about high-sensitive troponin. High-sensitive troponin now, it is better than the traditional troponin, because traditional troponin, I or T, usually elevated after 6 hours. But this is here have to be, usually it is elevated at the 0 time. If we have a patient with chest pain, we have to do high-sensitive troponin. If it is positive, that means this patient is acute coronary syndrome. If it's negative, then we have to repeat it after 1 hour and up to 3 hours. But up to 3 hours, if it is negative, this is definitely is not a case of acute coronary syndrome. So we can discharge a patient, okay, and we are sure there is nothing will happen to him. Okay, in this chest pain unit also does not only have to be ECG and troponin, have to be echocardiography, bedside echocardiography, and well-trained doctor, and this we have to do for him echocardiography. From academic point of view, sometimes we teach our students that if a patient comes to you with a chest pain and you have normal ECG, that does not mean this is a case that you don't have a MI. So you have to keep him okay in the emergency department, and you have to follow up the patient by serial ECG and echo. But now we have to do for him echocardiography, and we have to see regional wall motion abnormality. According to the distribution, which coronary arteries involved, for example, any one of this, like this is whether it is supplied by right coronary, left coronary, okay? And then, if the ECG is normal, and the echo, so some regional wall motion abnormality, that the patient definitely have acute coronary syndrome. Again, by time, as I said, that is much progression happen in the cardiology field in medicine. Sometimes we find that a patient with acute coronary syndrome, an absence of regional wall motion abnormality. Now this new technology of echocardiography, this one, what we call it a global longitudinal strain pattern. It will assess the strain pattern, velocity of myocardium. Usually divide the brain in about 16 points. And this everyone, there is some related to the which one coronary artery. For example, this is all of them are healthy. Here there is some sort of ischemia. We put it -18 is the cut line, whether it is above it or below it. This is normal or abnormal. In this case, if a patient has regional wall motion abnormality, there is no regional wall motion, and GLS, no, then we can say this patient don't have. But we find some patients that have no regional wall abnormality, and there is some problem GLS, then we have to admit the patient. But this is advanced and need good training, okay? And at least, but it will be solved some problem in case of a patient with a chest pain. And then the last things, we have to go to the coronary angio. Coronary angiography, now, this is new non-invasive procedure, give us a chance to diagnose or exclusion coronary artery disease Before, maybe 20, 30 years back, any patient with chest pain, we said have to be, in order to be sure that have coronary artery disease or not, we have to do for him coronary angio. And this is an invasive procedure, and with radiation, and while this is now, the percentage of people with a chest pain who refer back to coronary angio are much, much less than before. This diagram gives us an idea about how to treat a patient with acute coronary syndrome. As I mentioned, that we divide them into two groups, into acute aspiration MI and non-aspiration MI. If a patient has aspiration MI, then if the patient coming to a center with the facilities of primary PCI, you know what I mean by primary PCI, percutaneous sometimes coronary intervention. That means we treat the patient by balloon or angioplasty. Or if the patient, there is no such facilities. يعني احنا بالعراق كان ايام زمان كنت استاذ ذكر تعرف انه كان عندنا المركز الوحيد هو ابن النفيس وبعدين صار مركز ابن البيطار بس هسه الحمد لله والشكر يعني كل المحافظات فيها مراكز متقصره وحلتنا كثير من المشاكل حتى بالويست واليو اس اي only in just 30% of hospital they have facilities of coronary angio and not every center okay with cath lab they have a facilities of primary PCI that can be done 24 hours. So, for example, in my center in Armuk Hospital, we don't have a cath lab. What do I have to do? In this case, fibrinolytic therapy, thrombolytic therapy. Okay, so again, if a patient comes to a center with primary PCI, the best option is the primary PCI. But if a patient comes to the center without a cath lab, then in this case, we have to use fibrinolytic therapy. This is the same ECG that I show you. I put it here. The best option is the primary PCI. If it is not available, okay, and then we have to use thrombolytic therapy. This is study difference between the efficacy of primary PCI and fibrinolytic. Definitely primary PCI is more superior than fibrinolytic therapy, but again, fibrinolytic therapy, if it is given in the proper time, it carries good percentage of opening the coronary artery, especially if it's given in the first 3 hours. We can give fibrinolytic therapy up to 18 hours. And sometimes American cardiology recommend we can give it up to 24 hours, provided that the patient has heart failure or in shock, or there is arrhythmia or hemodynamic stable, or frequent chest pain. Otherwise, up to 18 hours. While primary PCI also have to be done time. Time usually, if the patient reaches to the center, where his primary PCI facilities are there, we have to do it within 90 minutes. The patient has to be on the cath lab. Otherwise, also, there will be maybe, we cannot solve the problem that you can. Here, I will just skip some of slide. That is, sometimes patient coming for he want to go to refer him to the center primary side. But such jam traffic, it is difficult. This is very difficult that the patient have to reach to that center within 90 minutes. Okay, so in this case, we have to do fibrinolysis even though the emergency, even though to the ambulance. يعني بقسم من أجل أنه يسووها بالسيارة مع الإسعاف. But have to be get a good team provide and have to be okay well trained. We can give thrombolytic therapy in the ambulance until the patient reach to the hospital. And usually this is in the West. And I say this is usually have this photo I took it. It is just a few days back. This is يعني شارع نطلع من مستشفى اليرموك باتجاه ساحة النسور. And you see such a jam traffic. If I want to refer a patient from my center to Ibn al-Baytar, if it is okay, no problem, the jam, the traffic, he can just arrive there within 15 minutes. But in such a jam traffic, we can just maybe need 3-4 hours. So in this case, fibrinolytic therapy is the best option. So, there are any patient with, if you want to give fibrinolytic therapy, there are certain or checklists we have to do it before giving it. Because there is a benefit, yes, but also there is a risk of complication. And one of them is the bleeding anywhere, and one of the most serious one is the intracerebral bleeding, which can happen up to 1 or 2%. But if we do good checkup of contraindication before giving the thrombolytic therapy, I think it is more safe. So in this case, we have to check the blood pressure on both sides, right and left, in order to avoid if the patient has dissecting aortic aneurysm or not. Provided the patient, blood pressure have to be also normal. If it is high, we have to reduce it before giving. If any patient has stroke, whether hemorrhagic stroke is completely contraindicated if it happened any time before, or while if it is ischemic stroke, have to be okay less or more than 3 months. in addition to other contraindication, what I'm doing, I put all these checklists in the emergency department, William Moore Hospital, and the residents there have to check it before giving the thrombolytic therapy. And it happened. So about a few, 3-4 patients, for my patient, they get cerebral bleeding because as a complication of the fibrinolytic therapy. Again, any other drugs which can have to be used in addition to the fibrinolytic therapy usually you give them loading dose of antiplatelet like aspirin. As I mentioned, the thrombus, there's a composite of it, one of the composition of it is platelet. So we have to give antiplatelet. We have to give loading dose of aspirin and loading dose of other antiplatelet like clopidogrel or ticagrelor or prasugrel. And there are certain indications for each one of them. Usually, okay, for how long we are going to keep this patient on this dual antiplatelet? The guidelines say that we have to keep on both antiplatelets up to 1 year. And after 1 year, we can stop one of them. Preferably have to be clopidogrel and keep the patient on aspirin for life. These are an example of antiplatelets which are used, okay, in a patient with acute, like clopidogrel, and this is Berlanta or ticagrelor and efficient prasugrel. We usually face in our daily practice that every patient with acute coronary syndrome and put on dual antiplatelet, they put him on proton pump inhibitor. No. Some patients, they need a proton pump inhibitor, like, okay, pantoprazole, in order to avoid the side effect of this medicine. So there are certain indications, not any patient. If a patient is 75 and above, if a patient has a history of active peptic ulcer, if a patient has a history of other anticoagulant he uses in addition to this, or a patient using non-steroidal drugs, or a patient using steroid, there is a risk of a bleeding from the ulcer, then in this case we have to use it. Which proton pump inhibitor? There are differences, but still the guidelines say that pantoprazole is superior than the other because there is maybe some interaction between other PPI and the clopidogrel and make the clopidogrel less effective.
So you have a slide.
Okay, I come to patient company. So, fibrinolytic therapy remains an important reperfusion strategy in a patient where primary PCI cannot be offered in a timely manner. Then, after this is acute management in emergency, you have to shift the patient to the CCU. In the CCU, he can take other medicine like beta blocker, and beta blocker is very effective in reducing the morbidity and mortality in the patient with acute coronary syndrome, and also we have to keep the patient maybe for life, and some guidelines say up to 5 years. Again, about the lipid. This is here sometimes we face a problem, that a patient with coronary artery disease and have normal lipid profile, even though a patient, we check the lipid and during his admission and found it's normal, we have to keep him on high dose of statin, and up to 4 to 6 weeks. And after that, we have to check the lipid profile. Coming back to the normal, okay, or coming back to the guideline, we have to reduce it up to 50% less than the initial one, especially LDL. If the patient is not coming to the target, then you have to add for him another drug, which is istimine. If not, patient is not coming after 4 to 6 weeks, we have to add PCSK9. Other drugs which can use with, and also in a patient with acute concern during admission to the coronary, are ACE inhibitor, which is also very important, and also to reduce the morbidity and mortality. This is a comparison study show the early efficacy of ACE inhibitor on mortality after MI in a patient receiving ACE inhibitor or a patient they don't receive ACE inhibitor, and you see that there is difference both in both groups and a matter of morbidity and also mortality. Short note, I am going to finish, about the management of non-STD patient. Non-STD patient MI, in this case, just I want to say that thrombolytic therapy you cannot use in a patient with non-STD patient. Only in a patient with STD patient MI, because there is even though sometimes some risk, and there is something theory behind it. In this case, we divide also our patient into 3 categories in non-STD patient. A patient with mild, and patient moderate, patient severe. Patients with moderate severe have to refer to cath lab immediately. Okay? If a patient with mild, then we have to treat him moderately, and after time we have to do for a stress test. If stress test is coming positive, then we have to refer for coronary angio. If the stress test is negative, then have to continue on medical treatment. I finish. Thank you.
Thank you, Dr. Thank you, Dr. Abbas, for this nice